And all right, hey, hello everybody. It's Dr. Alex Earl here. We're at Pure Plastic Surgery, and it's Hump Day with Dr. Alex Earl. And today we're very excited. We're on 3 platforms here today. I think it's the first time we do that. So we're on Instagram, of course, and a lot of you guys know me from there. And then we're on YouTube and on TikTok. I think maybe the first or second time on TikTok. So today I'm gonna kick it old school a little bit because there's hopefully quite a few people out there have not seen my lives before. And what is this about? So Hump Day with Dr. Alex Earl, it's all about going over plastic surgery topics. And so I'll go over a topic. I'll try to talk about the pre-op, the operation, the recovery, the potential complications, and then of course after that I'm happy to answer all of your questions, and we can go over really any plastic surgery topic when it comes to that. We can go over what I'm discussing that day, or you can ask me just pretty much anything that comes to mind when we talk about plastic surgery, okay? And from head to toe, so whether we're talking about facelift, breasts, tummy tuck, etc., we can answer all your questions, okay? And you know that you're getting good, reliable information because you're getting it from a double board certified plastic surgeon who's Princeton educated and Duke trained. All right? Okay, so here we go. So today we're gonna go over a pretty comprehensive review of the breast lift, okay? Plus minus implants, all right? So breast lift, the official kind of name for that is mastopexy. Okay, so mastopexy, and in the layman's term is the breast lift, and of course to that you can add an implant or not, depending on what your desires are, what your final look you want that to be. Okay, so there are different breast lifts, and that all depends on how droopy the breast is. Okay, so what I do here, there's different grading to the droopiness of a breast. Okay, so and the technical term for droopiness is ptosis. Okay, and so we have here a line that's what we call the inframammary fold. That's a fold beneath the breast. So if your entire breast is sitting above the inframammary fold, then you don't have any ptosis, and so that's a zero ptosis there. And those patients are then candidates for a breast augmentation. They don't need a lift at all. Okay. And then if you have the nipple position at the level of the inframammary fold, okay, then that's what we call a grade 1 ptosis. And so for grade 1 ptosis, then we're typically only needing a very small lift, maybe about anywhere between 1 to maybe 3 centimeters. And so for that, we can do what we call a donut lift, where we're just making an incision that goes around the areola. All right, so let me draw a breast this way. So that's kind of the breast. So we're doing a donut lift. The incision only goes around the areola there, okay? But that's only for very mild grade 1 ptosis, okay? Now, if the nipple position now falls below the inframammary fold, but it's not the lowest point of the breast, then that's grade 2 ptosis. And for that, we're typically doing what we call a lollipop or vertical pattern, where we go around the areola, but there's also a vertical scar that goes from the areola down to the bottom part of the breast, okay? And then lastly, the most severe type of droopiness, okay, is the grade 3 ptosis, and that's where the nipple position is certainly below the inframammary fold, but it's also the lowest point of the breast. So basically, nipples pointing straight down. So nipples pointing straight down, that's grade 3 ptosis, and for that we typically have to do this anchor type pattern in terms of the lift. So it goes all the way around the areola, down towards the bottom of the breast, and then underneath the breast like that. So that's a typical anchor type pattern for the grade 3 ptosis. Now, it's not all completely cut and dry, right? So sometimes for a grade 2, you'll still require that anchor type pattern, okay, for the most optimal result. So here, especially here in South Florida, a lot of our patients want to get as much lift as possible. They really want to have the breast, as high as they can, with a fair amount of fullness in that upper pole. And so then for that, in order to get as much lift as possible, then we typically go for that anchor type pattern. The other kind of downside sometimes to that lollipop pattern is that the areola tends to want to stretch out over time. So the areola, which we make small at the time of surgery, then starts to kind of stretch out over time. Then we have a lot of patients that then come back and they're like, I want to reduce the areola again. And so sometimes that can happen with that lollipop or that donut pattern. The donut pattern is rarely used because it really is for very, very mild ptosis. You try to do anything that's more than say 1 to 2 centimeters with a donut pattern, it's not going to look good, and that areola for sure is going to get large, it's going to get huge, and the patient is going to be very, very unhappy. And typically we then have to bring them back to then turn that donut pattern into an anchor pattern and reduce the areolar size there. Okay? Now with any of these lifts, of course, you can add an implant. What does an implant give you? Well, an implant's going to give you more fullness in the upper pole of the breast. It can sometimes give you a more cleavage if that's needed. And of course, for those patients that need volume, it's going to give you volume. So who are these? A lot of times after undergoing breastfeeding, maybe having multiple kids, you lose a lot of volume in the breast. We have what we call kind of like a deflated breast or empty bag type of breast, and so you're going to need to add volume, and so definitely you can use an implant for that, okay? Or sometimes you just want more fullness in that upper pole, and so the implant's going to do that as well. What can sometimes be tough is when you have a patient that has a fairly full breast, but they still want that implant to give more fullness in the upper pole, but want to reduce the overall volume of the breast. That can get pretty challenging. Remember, when we're adding an implant, we're by definition adding something, right? We're adding volume, and then we're trying to take it out from the breast tissue itself. But you can't reduce the breast as much when you're adding an implant than when you're not, because you're adding that volume that belongs to the implant as well. Okay, so it's very tough to do an overall breast reduction and add an implant. Okay, all right. So how do you prepare for your breast lift? Okay, so you got to undergo all the kind of preparation that we do for any surgery, of course. That, which means all your laboratory work, your EKGs, which is we're checking on the heart. You got to get your medical clearance from your primary care doctor. Okay, so we got to do all that. But on top of that, there's 2 things to keep in mind specifically for this surgery. Okay, so one is breastfeeding. So we get this question all the time. Doc, when can I have my breast lift or breast lift with implant surgery? I'm currently pregnant, or I'm scheduled to have a C-section in a month. When can I have the surgery? Okay, so the key thing is that it all has to do with breastfeeding. Okay, so you have to wait at least 6 months from when you stopped breastfeeding. Okay, so it's not about when the child was born, when you had your C-section. It's not about that. It's about breastfeeding. So 6 months after breastfeeding, that's when you can have your breast surgery. And why is that? Because before then, those ducts, okay, where the milk is coming through, those ducts are open. Okay, and when you have open ducts, that means there's essentially a connection between the breast and the outside world, and so then potentially bacteria can get in there. Okay, also when you're breastfeeding, there's bacteria, not a lot, but there's some bacteria in the mouth of the baby, and so the risk of infection is a lot higher if those ducts are open. So you want to make sure that those ducts are fully closed, fully sealed before you then undergo your breast lift plus minus implant. Okay, so at least 6 months from the day that you have stopped breastfeeding. Okay, and the other thing that's really important, of course, is your mammogram, right? So now coming up in October, we're going to be talking a lot more about that in October. It's Breast Cancer Awareness Month, right? And so one of the things that you want to make sure is that there's no issues with the breast potentially before you do the surgery, right? That there's no potential tumors or anything else that's going on. And so if you're over 40 years old, then you definitely need to do a mammogram plus minus an ultrasound before undergoing your breast surgery. Okay, that way we can make sure that there's no suspicious lesions, no tumors, or nothing like that. If we do find one, then we can proceed with surgery. You got to have that worked up first, right? You got to have your biopsy, make sure that it's something benign and nothing that needs to be further treated before undergoing this type of surgery. Okay, so very important. All right. Okay, so you're ready to do your surgery. All right, and then you're gonna come in day before surgery. We're gonna talk. You're gonna show me kind of what maybe you'll show me your wish pictures. Maybe you'll just describe kind of what's the look that you're going for. And from there, we can determine the type of lift that you're going to have and the volume of the implant that you're going to need to try and achieve that look, okay? Now, there's one thing that is very, very important, and I discussed this with all my pre-op patients with all my patients at the time of pre-op. A breast lift with implant is not the same as a breast augmentation, okay? You have to understand that. So a lot of times we have patients that come in for a breast lift with implant, they have very, very droopy breasts, and they're showing me their wish pics, and it's all breast augmentation patients, okay? That's not going to be realistic, okay? You can never make a breast lift with implant look the same as someone that has like a small A-cup breast with tight skin and has like that super, super rounded, very, very high look, okay? Why? Because we're starting from a very, very different foundation, okay? When we're starting with a droopy breast, that skin is poor quality skin. Typically it's been stretched out. A lot of times it actually has stretch marks, which is an indicator of poor quality skin. And so that skin is never going to stay tight for an extended period of time. So even though I can get things very, very tight in the operating room, what tends to happen over the course of the first 3 months is that skin tends to stretch out, okay? And tends to stretch out, and things will then relax a bit. And so you're never going to be able to achieve the same look with a breast lift with an implant as you are from a straight breast augmentation, okay? So you got to set realistic expectations, and that's part of the discussion that we undergo when we do the pre-op, especially if the patient is bringing me wish pictures that are a bunch of breast augmentations, which is not the same thing. We cannot achieve that, okay? I hope that's clear. All right, so we do our pre-op. Next day will be surgery day, and then after that starts the recovery, okay? So initially, during recovery, we're going to give you a surgical bra, and you're going to be wearing that surgical bra for about a week, okay? And then after that, you can switch to a sports bra. So typically a sports bra that opens and closes in the front is the easiest, all right? The only thing you got to make sure that there's no underwires, okay? No underwires for 6 weeks. 6 weeks, no underwire bra, okay? Also, for those first 6 weeks, we're going to limit your activity in the sense that there's no strenuous activity and no heavy lifting for the first 6 weeks. So not much more than 10 pounds in the first 6 weeks, okay? However, range of motion, that's what the ROM stands for here, range of motion is okay. You can gently move your arms in any direction, okay, as long as it's not strenuous or you're not lifting anything heavy. Now, this is my preference. There are surgeons out there that will tell you that they want you to limit range of motion for the first 2 weeks and do what they call the T-Rex arms, right? And you're walking around like that, like a little T-Rex. That's not really my preference. I think if you're just, you're not doing anything heavy, nothing strenuous, you're taking it easy, then range of motion is okay in any direction, all right? Also in the first 6 weeks, do not submerge the breast underwater. So no swimming, no bathtub, no jacuzzi. Just do not submerge the breast underwater for the first 6 weeks. Of course, showering is okay, but your first shower is going to be 48 hours after surgery. So 48 hours after surgery, that's when you can start showering. Soap and water can hit all the areas. You can use a dial antibacterial soap, and that's typically the best thing to use. Okay? All right. Now, when you first come out, these implants are going to look like they're way too high. They're going to be like sitting up here, okay? And the breast is going to look like it's sitting below the implant, and it's going to look a little odd, and that's expected, okay? So when you first come out, things look a bit odd. It looks like the implant is way too high. The breast is sitting a little bit low, okay? And what's going to happen is that implant's going to settle, and it's going to take 3 months. 3 months to settle. There's no way to make this go faster. So if you're like 6 weeks and you're like, doc, my implant still seems a little high. Well, you're only halfway there. I know it seems like a long time, but it's going to take at least 3 months for everybody, okay? And when that implant settles, it'll come down a bit. It'll round out the bottom of the breast. The nipple position will come up to the front of the implant, okay? And everything will take a nice, beautiful shape. And like I said, but at least a 3-month slow, gradual process. All right. One thing that you can expect when you do a breast lift is loss of sensation to the nipple area. How much? I can't really tell you. It varies a lot from patient to patient. So in some patients, you know, they can have normal sensation. Other patients, they can lose quite a bit. Honestly, for most patients, it's something in the middle. And what I can tell you though is that it's worse at the beginning and it can improve over the course of the first 12 months as some of those little nerve endings grow back into the nipple area, but it may not come back to completely normal, okay? So that's something that just needs to be accepted. If you're gonna do a breast lift, there may be some loss of sensations in the nipple area, and there's no way around that, okay? All right, so that's why that falls into recovery, and I wouldn't even really consider it a complication. It's just part of the surgery, all right? Okay, so, but what we do have to talk about are complications, okay? And I talk about this with every surgery that we discuss, because the only way to have 0 complications is to not do surgery, right? So the key is not to try to go to someone or somewhere where there are no complications. The key is to try to go to someone who has minimal complications, less than the national average, such as us here at Pure, okay? But if you're expecting to have 0 complications, that's not a realistic expectation, okay? Every surgery carries risk, no matter what surgery you're doing, not matter the surgeon, you know, the surgeon or anything else, okay? There's gonna be a potential risk of complications, okay? So what are the potential complications with this surgery? So, of course, you have infection, and that's with any surgery, especially when you're cutting the skin. So we're gonna give you antibiotics during surgery, the IV, and then you're gonna have oral antibiotics for a week after surgery to try to minimize this risk, okay? But once again, it's never 0, but for a breast lift with implants, it's fairly low, typically in the maybe 1 to 2% range. All right, why can't it be 0? Because we all carry bacteria. We have bacteria on our skin, we have bacteria in our nares, there's bacteria everywhere, okay? So that's why you're never gonna have a 0% infection rate, all right? But we do try to keep it very, very low. Scarring, of course, this depends a lot on the genetics of the patient. You know, of course, the more of a lift that you get, there's more incisions and more potential risk for scarring. But, you know, just some patients also have a tendency to have hypertrophic scars or keloids. So unfortunately, a lot of that has to do with genetics, but we also can work the scars. So starting at 2 weeks post-op, you're gonna start using a silicone-based scar cream. We have one here called Siligent. That's the name of the scar cream that we recommend there, Siligent. And you're gonna start using that at 2 weeks to try to get those scars to be as flat as possible. In terms of the color of the scars, they're always gonna start off much darker, and then they tend to lighten up over the course of several months. And remember, it takes up to 12 months for a scar to mature, up to 12 months. So we can keep working that scar and getting it better and better for up to a year after surgery, okay? The next one is bleeding. Of course, anytime we're cutting skin, we're doing surgery, there's potential for bleeding. And what we're talking about here more are what we call hematoma, so bleeding after surgery, right? So there's 2 places where you can bleed. You can bleed in the pocket where you put the implant, or you can bleed, you know, in the underneath the skin when we do the breast lift, or what we call the flaps there, okay? Now typically if it's a small hematoma, it's not a big deal. Usually we just kind of treat that conservatively and your body can eventually absorb it. If it's a larger hematoma, sometimes we do have to go back to the operating room so that we can wash out the hematoma. It's very rare that when you take someone back that you actually see something bleeding, but occasionally you may see it, and then of course you cauterize it or tie it off at that point in time. All right. If the hematoma is inside the pocket, a lot of times you have to remove that implant, wash out the pocket, and then put in a new implant. If it's outside the pocket, then a lot of times we don't open up the pocket at all. We just wash out that superficial hematoma and close the skin back. Okay. So what are the chances of that? Hematoma is very low. It's less than 1%. I probably get maybe 2 a year that we have to go back and wash out. Okay. All right. Capsular contracture can happen anytime you put in the implant, whether it's breast aug or breast tip with implant. That's where the wall around the implant gets thickened, and then that wall can basically start to kind of crunch down the implant, and it makes everything very, very tight and starts to feel hard. Okay, and so when that happens, a lot of times we do have to go back and remove that capsule and exchange the implant. Okay, and if you get an early capsular contracture, meaning probably within a year, a lot of the times that's covered by the implant manufacturer itself. We use Natrel here, and if you get an early capsular contracture with a silicone implant, then they'll cover the implant exchange procedure for you. Okay? And then bottoming out is part of the issues that we have when you have a very, very kind of loose, poor quality skin. So if that skin is not good quality, a lot of times with the weight of the implant, it basically stretches out again and stretches to a point where you have to go back in and remove more skin, right? So there's a lot of plastic surgeons out there that won't do a lift and an implant at the same time. They'll stage it. They'll do the lift first, and then they'll come back and put in the implant, okay? But here's my thought process. If you're doing that, then the chances of needing 2 surgeries are 100%, right? But if you're doing it all together, okay, and you have the expertise to do that, then, probably only about somewhere like, 15 to 20% of people have to come back because they bottomed out. All right? So that means that the overwhelming majority of people, at least 85% of people, are basically one and done. Okay? But it is something that can happen. Okay? It's not a low number, maybe 15%. All right? That they do bottom out, that skin stretches out, and we do have to go back to the operating room to remove that more skin. And sometimes if you have a bad case of bottoming out, we have to add in some support. And that's the internal bra you may have heard of. It's a mesh. We put a mesh inside to give support to the implant. That's the internal bra. And a lot of times to do that, we have to go back for bottoming out. All right? Now, what is common also is what we call wound breakdown, especially at that triple point. This is a triple point here. Okay? So, right there, where that vertical and horizontal scar meet, we call that the triple point. That can sometimes open up. I would say about 20% of cases. That can open up, but it's typically not a big deal. It's not a big deal. We just treat it with some antibiotic ointments and dressing changes, and then it heals on its own. Okay? So don't be too freaked out if you see that. You just let us know. Our nurses will walk you through how to take care of it, and it'll be okay. All right? And now what's the most dreaded potential complication? All right? The last one left here. The most dreaded potential complication is nipple necrosis. Anyone know what that is? It's basically nipple death. All right? The entire nipple and areola turns black, it dies, and it falls off. And that's terrible. That's a terrible thing to happen, okay? But it can happen. Everyone needs to be aware that it potentially can happen. The longer the breast, the higher the chance of that happening. Okay? If your distance from your, what we call the sternal notch to your nipple is greater than 30 centimeters, then the chances of nipple necrosis start to really go up. Okay? Unfortunately, if you go to someone with a lot of experience doing this, it's very, very rare. Much less than 1%. I have never had a full nipple necrosis, and I've only had like 1 or 2 partial necrosis. Okay? But it's something that can definitely happen. Like I said, the longer the breast, the higher the chance of that happening. And part of what I do, if the distance is very, very, very long, then you should not be adding an implant in that. Then you definitely want to stage it. You want to do your lift first, and then come back and add the implant. Because when you're adding the implant, you're adding potential complications. You're adding more pressure to that nipple area. Okay, and then the chance of necrosis goes up higher. So why does that happen at all? Because your blood supply, you're keeping blood supply to the nipple and the areola, right? So you can only really remove so much tissue before you get into trouble. And if that blood supply has to travel a very, very long way, then you really, really have to be careful. Okay? So nipple necrosis, very, very low chance, but it's not zero. All right? Okay. All right, I'm happy to answer any questions regarding this or really any plastic surgery topic.
First one, could you repeat the name of the scar treatment, please?
Yes, so we use Incision, and let's see, I think we have the pamphlet here as well. All right, so I'm gonna put that there. Can you guys see that okay?
TikTok.
Yeah, okay.
YouTube.
All right, so Incision, it's a great scar cream. It's silicone based. It can come in the cream form, also can come in the strips, and I highly recommend that starting at 2 weeks post-op. You're going to want to use that for at least 3 months. After that, if everything's going well, I know it can get a little bit expensive, so then you can switch out to something like a cocoa butter moisturizing lotion or sometimes vitamin E oil.
Okay, Doc, let's go to the BBL area. Can you do fat transfer to hip dips only?
Yeah, of course. So you can tailor your BBL, however you want. It's still a BBL though. It's not, it's not really anything different. Or if you want to break it down, it's still liposuction with fat transfer. But if you want to just address the hip dip area, you can do that. And then, you can tailor, of course, how dramatic or not dramatic you want to go. Nowadays the trend is more towards like more enhanced natural looks, and by that meaning enhanced natural to that patient's very own foundation.
Okay. This one, would you do a mini thigh lift in conjunction with liposuction?
So typically we don't combine any kind of surgical procedure with liposuction here in Florida. Now that of course depends on the state. Unfortunately in Florida, once you make an incision, okay, even if it's a small incision like a breast augmentation, a little tiny 3 centimeter incision, then we're limited by the Florida Department of Health to only remove 1 liter of liposuction at that time, and which is typically not enough to really get the look that you want with the liposuction, unless you're starting with a fairly low BMI.
Okay, Doug, can you remove fat necrosis from a BBL?
Right, so okay, that's a good question. So first of all, let's explain to everybody what that is. So when you're doing your BBL, you're doing your fat transfer, right? There's basically 3 things that can happen to that fat. 1, it survives. 2, it just gets absorbed. 3, it neither survives nor gets absorbed. Basically, the fat dies, but it stays there. It becomes a scar ball, and we call that fat necrosis. Okay. Now, sometimes if you have very, very small areas of fat necrosis, there's nothing. You don't really need to do anything at all. Now, if you have a larger area, say golf ball size or bigger, then there are a few options. Okay, depending on how aggressive you want to be. If you really want to get rid of the whole thing, a lot of times then an incision has to be made over the area. You got to basically go down, remove the entire fat necrosis, and then close everything up, and that's going to leave a scar. So that's typically not my preferred option. What I like to do is get in there with a cannula. Okay, so small incision, same way cannula, just as I was doing fat transfer. Try to break up that fat necrosis, break it up as much as I can. Okay. And that allows your body to absorb at least some of it. And so when you break up this hard ball into like multiple little tiny balls, your body can deal with it better. They can absorb some of it. Sometimes you can fat graft kind of around the area, and so then you don't feel that that hard ball scar tissue anymore.
Okay, Doug, here for TikTok.
All right, TikTok question. All right.
The loss of sensation can happen with an implant augmentation?
So with a straight up breast augmentation, it's less likely, especially if you're doing your incision from the bottom, right? So if you have your breast, right, and you're making your incision through here, what we call the IMF incision, then it's very unlikely that you'll have any issues with sensation. Now, some patients like to have their incision through here, what we call the Infra areolar incision, okay? When you do that, the chances are higher because you're cutting right around that area, but you're not cutting fully like when you do these lifts. You're not cutting all the way around. So it's less chance, but there's a small chance, like almost 0 chance with this, small chance with this, and of course, fairly high chance with your true lift.
Okay, Doc, for Lipo 360, do you try to take out all 4 liters even if there's a minimal fat transfer?
Yeah. So the lipo part's the lipo part. We if you have 4 liters to remove, we're certainly going to remove that. Even if, say, for example, you're just asking for your hip dips to be filled, right? I don't have to use all the fat, so I use the fat that I need, and then the rest, of course, just gets discarded. Unfortunately, we don't have fat banks, which would be awesome. I'm gonna have my people in the lab work on that, because that would be great to have, where you can bank that fat and then come back if you wanted more transfer, especially with the hips, because we don't, hip survival is so variable. We're gonna lose about 30%, but some patients can lose a bit more. So that technology is not out there, but yeah, so we remove the 4 liters, we use what we need to use, and then unfortunately for now, it'll get discarded, and hopefully one day we can bank it.
Yeah. How long after a gastric sleeve surgery can you get a breast reduction, and what is required BMI at that point in time?
Right, so after any bariatric surgery, so whether it's a gastric bypass, gastric sleeve, etc., you typically want to wait about 6 months, okay? Because what happens once you have that surgery, you go through a rapid weight loss phase, and then you kind of come to like a low point, and then you typically come up a little bit, and then you stabilize. And you want to be in that stable phase when you have your surgery to remove all the excess skin and everything else. Okay, so and that usually happens somewhere around 6 months. But the key is that your weight is now stable. Okay, and then what was the second part? The breast
and the BMI.
Oh, and the BMI. I'm sorry. So and the BMI is the same. Your BMI has to be under 30.
Okay. Let's keep going.
All right.
Okay, some surgeons says like they fix stomach muscles, rib to pelvis, not just in the middle. What's the best?
Rib to pelvis. I think they're still talking about the middle as far as I understand. So the stomach muscles are fixed from what we call the xiphoid process, which is up here. So that's just the lowest part of your breastbone or the sternum, and from there, yes, all the way down to the pelvis. Okay, but you're bringing them in that direction from here, basically in between the ribs, all the way down to your pelvis. Okay, and that's why we have to dissect that skin all the way up top. So we lift everything up all the way to the top of the abdomen, and from there we start repairing the muscle all the way down to the pelvis.
Okay, there's some multivitamin for bariatric patients that you recommend?
That I'm going to leave up to your nutritionist. Okay, so I'm certainly not an expert in that. So definitely, speak with your nutritionist. Most patients that are having bariatric surgery kind of are almost required to have one because there's definitely going to be shifts in how they absorb things. They may need different supplements and things like that. So your nutritionist should really be on top of that. But what we do want, we want you to be nutritionally optimized before surgery, because if you have low levels of certain vitamins, then you may not heal well and you're more prone to infection and open wounds.
Okay, so doc, I need a second round of breast reduction and lift.
Yeah.
Because the first one was 7 years ago. Is it safe to do it now?
It's safe, but you got to go to the right person. Okay. Because it's definitely more challenging. It's more tricky, okay? So, but it's a great question. I'm glad you brought it up, because this can certainly happen, right? So when you have your, even if it wasn't 7 years, maybe you just had a breast reduction. But the problem is that you can only remove so much tissue at one time. If you're overly aggressive, then you run into this problem, the dreaded problem, nipple necrosis. Okay, if you remember, we gotta keep a certain amount of blood supply to that nipple area. And if we're too aggressive and remove too much tissue, then you lose that blood supply and your nipple dies, and that's terrible. Nobody wants that. Okay, so if you start off with a very, very large breast, I'm talking like G, H, F, extremely large breast, it's impossible to get you down to like a B cup or even a C cup. Okay, it's impossible without causing problems. So a lot of times you do have to undergo 2 breast reductions. So you do your first one when you reduce most of the breast. I've removed, like 2.2 pounds, 3 pounds of breast tissue. All right. But then if you want to still reduce a bit more, then you have to come back for a second breast reduction. All right. And it can be done safely, but the surgeon needs to have experience and they need to know what type of a reduction you had the first round to make sure that there's no issues with the nipple and potential nipple necrosis after the second round.
Okay, Doug, how do you decide the size and type of implants?
Right, so that we determine together, and it's kind of a system that we call kind of smart aesthetics, where we kind of combine the patient's desire with their measurements, okay, in order to choose the best kind of implant for them. So it's not completely kind of just, whatever you want, right? The implants have to fit your body. So it does depend on a lot of objective measurements that we take during your pre-op. And so combining those measurements along with, the look that you're going for, and based on my experience, then we're able to choose the best implant for you.
Okay, here. Can you contour abdomen with Lipo 360?
Yeah, definitely. So you can do your Lipo 360, which just means lipo across the entire trunk. So abdomen, flanks, and waist and the back. And you can add to that what we call HD or high definition lipo. And so when you do the HD lipo, you're contouring the abdomen, you're going for that athletic look. You're basically creating the abs, which are the ones that go here, and sometimes even what we call the obliques, which are the muscles that go along this way, and you can etch that out during your Lipo 360.
Doug, speeding stitches, you cannot pull, but it's out. What can we do?
So you can try to pull it, see if it'll come out that way. If it doesn't, then pull what you can and then cut it at the base. And then typically your body then will just take care of the rest. But you do have to take care of it, because if you don't, that little wound that occurred to spit out the stitch, it won't heal until that stitch is out.
Okay, and this is one of the questions we got. Can you get lipo and tummy tuck together?
So you can only get, like we said, like the limited lipo that's allowed here in Florida, which is 1 liter. So when we do the tummy tuck, we typically only do lipo to the flanks and the waist. All right, and for most patients, that's about 1 liter of fat removal right there. So we can't really go into other areas. We don't go in the central abdomen. We don't go in the back or anywhere else. Okay, so what we cannot combine here is typically a Lipo 360 with a tummy tuck. Okay, you're just not going to have enough. We don't have enough ability to remove fat. We only have that 1,000 cc's. And so it's just not, in terms of bang for your buck, it's really not going to do anything for you. So the best is to focus on that flanks and that waist, so create that nice contour look. And then if you need more fat removal to the central belly or the back or everywhere else, then come back, okay, for a second surgery around 3 to 4 months later. And at that point in time, we can do an entire Lipo 360 plus minus fat transfer.
Okay, Doug, the last one.
Right.
Do you do areolar reduction without leaf or without implants? So
Yeah.
just areolar reduction.
Sure, yeah, you can do that. We call that an areoloplasty, and we can do that with or without implants, with or without lift. And it's actually fairly simple, pretty straightforward surgery. But it's a good thing you bring that up, because an areolar reduction comes with, it's pretty much a part of any lift. So any like donut, lollipop, or anchor, any type of lift that we're doing is actually part of that, kind of already included. So you don't have to like add that, in addition to the lift. It's part of the lift itself.
Okay, no, I like this one. So another one.
All right.
Doug, if I don't have enough fat, like the 4,000 cc's for a BBL, where else can or will you take fat from?
Yeah, so we can always add other areas. So what comes standard with your lipo BBL basically is your Lipo 360, okay, which is the entire trunk, abdomen, flanks, waist, and back. Okay. Now, if we want to add fat from other areas, then we can add on, for example, the inner thighs, the arms. Okay, those are other areas we can add on. And then this one doesn't really contribute a lot of fat, but a lot of people like to add on the chin area so we can contour that chin better and have a nicer, more acute angle between the neck and the chin area there. Okay?
Okay, so that's all.
All right. Awesome. Well, I hope you guys learned a lot here today. I hope the TikTok people are starting to follow. And remember, this is a place where you can come every Wednesday, typically around 4:30 p.m., maybe 5 p.m., so you can learn a lot about all sorts of plastic surgery topics. And I hope to see everybody here next week on Hump Day with Dr. Alex Earl. Take care, everyone. Ciao.